Hello, my name is EshikaParuchuri, and I'm studying 11th grade at the Woodbridge Academy Magnet School in New Jersey. I would like to begin by thanking you for joining me in this initiative. My main objective is to educate and empower adolescents around the world by working with experienced doctors across different specializations around the world to help them construct a healthier lifestyle. In addition to promoting health education, I hope to inspire interested teens to pursue careers in healthcare, not just as future leaders, but as individuals who are prepared to respond to urgent public health challenges, from everyday medical needs to global health crises like the COVID-19 pandemic. Welcome to the Healthy Teens podcast. I hope you are keeping well. This month, I'm joined by Dr.Santosh Swaminathan, who specializes in bariatric surgery. He has extensive experience in this field, currently working as a board-certified bariatric surgeon. For this episode, we'll be focusing on bariatric surgery, public health issues that concern teens, as well as steps that can be taken to achieve a healthy lifestyle. And now, Dr. Swaminathan, can you give us a little background regarding your experience in this field?
Hello, everyone, and thank you, Eshika, for this opportunity to interact with your audience. And it's a great pleasure, especially chatting about this important topic, especially about obesity, as well as its effects, as well as how big a public health problem it is. Again, my name is Santosh. I'm a current bariatric surgeon here in South Carolina, United States, and this is my passion, and looking forward to having a healthy discussion on all aspects, maybe dispelling some myths about bariatric surgery.
Of course. So now let's dive right into our questions. First, we'll begin by discussing what bariatric surgery is. So firstly, what is bariatric surgery and why is it performed?
Yeah, bariatric, the word bariatric surgery actually comes from, a combination of Greek words, but overall it's about, it's essentially an additional tool that helps patients with obesity achieve sustainable and successful weight loss. And these are patients who've tried multiple other measures and have either failed or had insufficient results, who seek these particular procedures. But yeah, it is a type essentially, commonly called weight loss surgery. Although the new term that we use amongst professionals and medical professionals is actually called metabolic and bariatric surgery, not just bariatric surgery alone.
Mm-hmm. And how do you determine if someone needs bariatric surgery? I know you said there are usually measures taken before, but what other factors are there?
Yeah, so, most insurances as well as scientific evidence relies on BMI. Not ideally the appropriate index, but unfortunately that's what we're going to go with at this point. We basically look at their BMI, and if your BMI is above 40 without any medical problems, or if the BMI is 35 above with medical problems such as diabetes, hypertension, or sleep apnea, that would basically bring you candidacy for potentially being a candidate for bariatric surgery. Obviously, a lot of it depends on insurance coverage, especially in the United States. But these would be the medical indications.
Mm-hmm. Could you explain some of the main types of bariatric surgeries and how you help patients choose between them?
Yeah, so we actually, in today's day and age, I would say we have two broad types. One I would say is endoscopic, and one is, surgical weight loss procedures. Endoscopic could be the intragastric balloon or endoscopic sleeve gastroplasty. These are all done endoscopically, so no incisions. And then we have surgical, which is, conventional surgery, where we have sleeve gastrectomy, and then we have a Roux-en-Y gastric bypass. And the third type is sleeve plus procedures.
And what organs are affected by bariatric surgery?
I am hoping when you mean organs are affected, I'm going to refer to this as more like a positive effect, if anything, is I would say it's a global phenomenon. I mean, we actually in medicine, if someone asks me what is the largest organ in the body, I would say skin, even up to that. So everything is affected by bariatric surgery in a very positive way. The whole milieu, as we call it in scientific terms, or interior environment of the body is changed because all your pro-inflammatory sequences or cycles are disrupted and the inflammation reduces throughout. But be more specific in terms of organs, I would say fatty liver disease or liver. We can talk about, or as they call it nowadays, as non-alcoholic fatty liver disease. Your heart, the function of the heart improves, as well as risk of cancer across the body, including especially in females with breast cancer or gynecological cancer.
Mm-hmm. And is there a certain bariatric surgery method that is usually considered the safest?
That's a great question. I think then this is a good time to do some myth busting. All bariatric operations are considered safe and effective. It just is dependent, and this is one of the most interesting aspects of this field. Is it's not it's not one procedure fits all, and at the same time, it's almost like a case to case basis. But all procedures are safe and effective.
Mm-hmm. And are there any potential complications or risks after surgery?
So I think any procedure, whether it's endoscopic or surgical, comes with its host of potential complications. But before we even speak of those, the overall risk of complications from any of these procedures in this modern age is tremendously low. We quote usually less than 5% for any complication and less than 0.5% for any serious complication. That being said, our society is working very closely with all surgeons to make sure they are fully certified to do this. They are all monitored and almost audited when they do these procedures for every little thing that you can imagine. And that being said, there are some complications. I would say, the major or the most serious I honestly consider is the opposite of what has been going on, which is basically malnutrition. So if patients sometimes fail to get enough protein or fail to drink enough water, I think that can lead to some trouble down the line. But that's where preoperative counseling and post-operative follow-up is crucial.
Okay, and now we'll transition our discussion into talking about adolescent obesity and eligibility. So first off, how common is teenage obesity?
I mean, it has become a public health problem. There are, again, numbers quoted by everyone. Everyone has their numbers, but our society quotes currently, at least from when they had a survey in 2022, they are talking about a rate of 20% of obesity, and about 32% of children between the age of 10 to 17 are overweight. The word overweight, obesity, they're all semantics for based on the BMI, which again, we can get into later on as to if that's truly a right indicator. It's just basically one of those we chose. But anyone BMI about 35 is considered as obese. And so that is about 20%. And overweight is anyone with a BMI about 25, but below 35, and that's 32%.
Mm-hmm. And why do you think that these rates are so high among adolescents?
I think, any patient who's struggling or suffering with obesity has two factors to them. One is, I call it basically environmental and non-environmental factors. There are some are basically modifiable and non-modifiable. Some which are modifiable, I think, as we know, the advent of processed foods, fast food, and diet has not been on our side in terms of helping this situation. So that is one. Access to good quality food has become limited, including if you look at the healthiest foods in the supermarket are actually the most expensive. And so access is limited by economic situations. In addition, there is a tendency to discuss this in the society about how maybe some extrinsic hormonal use in production of this food is hampering some of the internal environments of hormones. So, like your external supplementation is kind of disrupting that internal regulation. And then, you do have still genetic factors. I would say some, like those are the non-modifiable factors. We are still studying the genes that are potentially leading to obesity, especially such early on. And also, the aspects like some medical problems or what we call secondary causes of obesity, like hormonal issues, or if they are taking medications that can cause obesity as a side effect. For example, taking steroids for asthma, things of that nature can also lead. And the global phenomenon, are they exercising enough? Are they getting enough physical activity? These days, a lot of the things are, not as difficult to get. Like, people don't have to even step out of their house to go get food these days. So it's, I think physical activity is also a key factor, or the lack of, rather.
And just branching off the physical activity you just mentioned, in some instances, is it possible that diet and physical activity can be ineffective for severely obese teens or any person in general?
I absolutely think so, because there have been studies, and this is always something we quote. And I'm going specifically to adolescents. At least one study that I can recollect, they did this study where teens were through, doing surgery versus just diet and exercise. And this was when they used to place gastric bands. I didn't even talk about that as a potential surgical option because we don't do bands anymore. But in 2010, a Journal of American Medical Association study saw that teens who had surgery had an average of nearly 80% excess weight loss, and who did excess diet and exercise had 13%. So I think you can clearly see the effectivity. 13% versus 80%. I mean, that seems a big difference. Or even if you run the statistics on that. So I think the word, and we should not confuse this, I want to make sure we all understand, is diet and exercise are still fundamental, and they are the whole fundamental based on which everything else depends. Surgery is just a tool in addition to diet and exercise. It doesn't mean you get the surgery or even the weight loss shots. Nowadays, there is also medical weight loss. So through the weight loss medication, or GLP-1, anti-obesity, whatever there's all these terms. Even then, you need to still rely on the fundamental of diet and exercise. So that doesn't take away from that.
Mm-hmm. Is there a general approach to treating obesity in adolescents?
Absolutely. I think it's not as simple as even one podcast can summarize it. I think it's a very, very detailed conversation. A lot of it is driven by parents. There are separate programs just for these. Not all hospitals actually even engage in adolescent bariatric surgery, but there are so many studies which are out there, especially longitudinal studies, which have looked at adolescent bariatric surgery over outcomes for 10 years, and it have proven patients have had a great long run, and it is safe and effective. So that's the first thing. How do we go about it is, again, depending on what their comorbidities are, which is basically what their associated medical conditions are. You may sometimes come across teens who potentially could be diabetic or have high blood pressure already, and with a BMI above 35, or even if their BMI is above 40, and they have failed measures such as diet and exercise. Those would be candidates, because as adolescents, we do have I would say, higher threshold a little bit. Just, we would try to see if they are going to benefit first from diet and exercise programs. We are not as aggressive as maybe in adults, but I think this surgery is still a very effective tool, mostly also to improve the fact that if they already have diabetes and high blood pressure, or we call it metabolic syndrome, this will basically retard that process or prevent it from becoming worse through their years. You don't want to see adolescents or youth be dealing with giving themselves insulin, and they are supposed to be out and out there and enjoying their life and being energetic and not have to deal with these things. But earlier the intervention, better the chance of reversing the effects of obesity. And this was again in a study in the Journal of, I think, Pediatrics in like 2010, which spoke about that there is no point in almost putting it off. The earlier you address it, whether it's medical or surgical intervention, the better.
Mm-hmm. And just going into more of the requirements for qualifying for bariatric surgery, is there a minimum age requirement?
So again, adolescents. So typically 13 is what our society says. 13 and beyond. Obviously, below 18, they wouldn't be able to consent for any of the procedures. So that's like one of those things we navigate with the parents, and obviously the child as the biggest stakeholder in this and understanding. So that's why childhood and adolescent obesity programs usually have a child psychologist or a counselor, and that's an additional person in addition to the usual team that an adult bariatric program has. There are programs certified to be an adolescent obesity center. Not all programs can be an adolescent obesity center. So then, because of the requirements, they need to have a pediatrician on board. They need to have like I said, a child psychologist or a counselor, or because a lot of these things do affect the psychology in a positive way, mostly because once there's a lot of this talk about body comfort, body positivity, and body, being comfortable in their own body situation. So we want to make sure the child is understanding what's going to happen, because this is significant weight loss, which is going to help them, but they need to be, physically and mentally prepared for it.
Do you think this age requirement might change in the future?
I think it could, because I feel like even from me being an adolescent to now, what I see in terms of adolescents and how smart everyone is and how informed they are and how adept they are at understanding information, I'm sure this could be pushed higher, like maybe starting at 10. But again, I think that stems from the same fact that earlier the intervention, the better. And there is no worse outcomes by doing this in these patients. Like, we've basically transposed the great results we've seen in adults to adolescents. So I'm sure the boundaries can be pushed higher.
Okay. And with that, we'll be shifting our discussion to talking more about the effectiveness and outcomes. So, is there a difference in the effectiveness of bariatric surgery for adolescents compared to adults?
Actually, no. Again, both of these, mostly the procedures done in adolescents are typically the gastric sleeve and the gastric bypass. That's what conventionally or traditionally, I guess, they have done. Now, if we talk about, I'll just get to the basic in terms of if you talk about complication rates. Let's start with that even. I know you asked me about effectiveness, but complication, first of all, is similar to that seen in adults. So it's not like any worse complicated or worse in terms of those outcomes. So it's very similar. In terms of the effectiveness, it is as effective, if not better, in adolescents than adults. In fact, 5 years follow-up data has shown patients who are adolescents who had the surgery show better weight reduction, improvement in medical conditions, and lower complication rates than those found in adults. So, if anything, it's better. And this is 5-year data, and obviously, I'll be happy to send some of this information over for your audience to look at, where you can tag some of these articles that will be highly beneficial for them to read through, because that way they can also be confident that we are not just making some of these numbers up. But yes, the 5-year data is pretty convincing. And 5-year data, I think, is pretty reasonable. In surgery, to get 5-year data on a lot of conditions is not very easy.
Yeah.
And I know there is even 10-year data coming up in some of the articles, but yeah, I think there's a good effectiveness, if not better.
Very interesting. And I know that the whole point of the surgery is to sort of help improve the BMI, but is there any like weight loss happening after surgery?
So to clarify again, that's one of the reasons why the society wanted to term it metabolic and bariatric. So we are looking at weight as only one aspect of this. We are trying to basically help them resolve their comorbidities, which is diabetes, hypertension, sleep apnea, intracranial hypertension, including even depression. There is improvement in mental health actually as well after these procedures. So yes, the weight loss starts. We in fact encourage weight loss even starting before the surgery, because they start working with the nutritionist. They work with the, like I said, the behavioral therapist or a behavioral, like a child behavioral psychologist, and they want to see the positive changes already made. We don't usually even approve a patient or put a patient through surgery until they are ready to make those lifestyle changes. And surgery is just a tool for you to achieve those lifestyle changes in a consistent manner. And so the weight loss, yes, happens, like I said, more rapidly in the first year, and then overall it kind of settles by 18 months. And then from there on, the reinforcement of these lifestyle measures continues to keep that weight off and keep them off trouble in terms of medical conditions.
Okay. And how would you define success beyond just sort of the weight loss numbers?
Yeah, see, that's the question we all ask ourselves: is what is success? And now, if you talk about solid numbers per se, you're just talking about have they achieved their target weight or excess weight, as you said. But I think there is things beyond that, like you mentioned. So for me, success means, have they been able to keep off taking medications for diabetes? Has their blood pressure normalized? Has their diabetes, or A1C as we call it, to check diabetes, stabilized? And the audience from your podcast has obviously has had the chance to listen to many other providers who have discussed these topics before. So basically, all those aspects, have they stabilized? Whether your heart condition is improved, and that to me is what is success. And in 20, I tell patients that, let's say I see them 20 years later. Obviously, I mostly deal with adult patients, but if I say that in 20 years, if they are healthy without cancer and mobile and without diabetes, and that's success. I don't care about the weight numbers as much as if in 20 years they were able to achieve this.
Very nicely worded. Are there any prevalent medical conditions in children with obesity?
Oh yeah, absolutely. I think like we touched upon earlier, one of the biggest and which is happening a lot lately is non-alcoholic fatty liver disease, and that has been a very, very big villain criminal in patients developing chronic liver disease as adults. And this is not even of their fault, as they would say, because it's not like alcohol or something that they did to themselves, but obesity is doing this to them. So that's one. Obviously, type 2 diabetes, high blood pressure, sleep apnea, poor quality of life, mental health problems, all these are prevalent in patients or in children who are suffering with obesity. And that's the first and foremost thing to understand, is obesity is also a disease. So we need to normalize that thought that obesity is a disease. It's not. It's like if someone was suffering from high blood pressure, you don't go stigmatize them for having blood pressure. Same thing with obesity. It's a disease and needs to be cared for, treated without stigma.
I agree. And are are there any psychological changes that obese children or teens are at higher risk for?
I think, and you might be able to probably put a better perspective since, you being an adolescent yourself, you probably will be able to say this, but in our own society, we discuss this all the time. One, the first and foremost thing, children with obesity are more likely to have health problems. So now they're missing school or they're missing important classes, whatever. Important, not even classes, I mean, even social aspects with other children. Like they're probably skipping or missing out on a lot of important milestones in their life as a child growing up, number one. And that can put additional taxation on your mental health. Secondly, children who have issues with obesity face discrimination, a lot of bullying because of their weight, and that can take place whether in their classrooms, in their neighborhood, even in their own home with their own siblings. And so this is this affects their behavior, affects their mental health very, very sharply. So I think in addition, there is significant association of depression, anxiety in patients with obesity by the nature of the disease per se that obesity does. And so I think that's that's one of the crucial aspects we do not somehow think about. We just always talk about hypertension, diabetes, blah blah blah, but the mental health is a significant piece as well.
Now we'll once again shift our conversation to talking more about recovery, nutrition, and just general post-op care. So, what does a typical meal plan look like in the months following surgery?
Yeah, so I mean, initially there's a recovery phase. We do a post-operative diet progression where they transition from liquids onto puree to soft, and then go to regular textures. The way I and everybody, at least in our programs and most programs, they get a nutrition handbook, which kind of literally sort of walks them through these steps. And that's where working with the nutritionist, the bariatric dietitian, as we call it, or is very crucial, whether it's adolescent or adults. Typical meal plan is essentially to get 60 to 90 grams of protein in a day, and to be able to drink 64 ounces of fluid, which ideally is non-carbonated, more so like water and other maybe non-sugary flavored water maybe, but avoiding carbonation as well as caffeine. So that is 64, and then the 64 ounces at least in a day, 60 to 90 grams of protein. I typically tell them that structure of the meal or structure of a meal plan for a day should be 3 meals and 2 snacks. So as contrary to popular thoughts that after bariatric surgery they want you to starve, it's actually the opposite. If you take 24 hours a day, if they're going to be sleeping 8 hours a day, so that's 16, and we want them to eat 3 meals and 2 snacks, that's basically 5 times a day that they're going to have to eat, which means they're eating more frequently than even before. And so every 3 hours, they're either getting a snack or a meal. And so a typical meal, like I told you, the whole construct is based on how much protein. So 60 to 90 grams. I'm not a big believer of decreasing calorie, like counting calories as they call it, because protein also, every gram of protein gives you 4 kilocalories, as you might have learned in chemistry, or so even if you take protein, you're going to increase the caloric intake, but that is good type of calorie to get, which is protein. So 62. So if you're able to satisfy 60 to 90 grams of protein, your stomach after bariatric surgery or your GI tract is not really going to have much more room to include things which are harmful for you, because it's going to keep you pretty full at 60 to 90 grams.
And are there any, just adding on to that, are there any other common nutritional deficiencies after surgery? And
yeah, so everybody
managed. Sorry.
Yeah, so no, everybody goes on a vitamin depending on the type of the operation. There's a daily vitamin with calcium. So those are the two things. So, you basically supplement them with a B complex, vitamin, folic acid, as well as vitamin A, D, E, K, and then you do calcium and iron. So we are lucky that we have so many companies now in the United States, for example, which manufacture bariatric vitamins. So now the patients have to take, it's like one in all. So like all the vitamins and iron they need are in one pill, and then they would just need to take calcium separately. So they don't need to actually take like 6 different tablets or something. So it's like one tablet. It's called a bariatric multivitamin with iron, and then they would do a calcium, and that's all they would need to do.
And what are some ways that you deal with a patient who isn't following their post-operative diet?
I think first thing, and I've realized this across time, is there is no point in there. I think I tell this thing to patients. There's no point in reprimanding them or being mean to them. It's only going to make them go distant to you. Okay. Mm-hmm. And that's the last thing you want, because in fact, when I see patients going through this difficulty, which happens, right? Human nature, I tell them that, this surgery, as I was telling earlier, is just a tool. You cannot change their mind in general completely, but these things are going to help you. At the same time, when I see a patient struggling through this, what I do is I make them see me more often. Mm-hmm. I make them, instead of their routine follow-up schedule, which is pretty tight already, they would see me like 1 week, 1 month, 3 months, 6 months, 9 months, and 12 months after surgery, and yearly after. I would see them, instead of that 3-month cap, I would see them in 6 weeks. So they are more accountable. And also, the first question you have to ask them is, why are they doing what they're doing? As in, what is the problem? Where is the disconnect? Are they having issues with access to food? Are they having issues with time at work? Are they having issues with stress at work? Are they having issues with, some kind of social judgment? And this is something I ask a lot of my patients around the 6 to 9 months. What does your family think about all this going on with you? Are they being supportive? Because it's very easy to sit here and think that everything is going to be so easy for them, but when they sit with their family for a dinner or for a meal, and everybody's looking at them weirdly and giving them the looks that why are you just eating like only that much? Like, what's wrong with you? Are you sick? Like they think they're sick, but in all they are trying to just do the right thing, and all of a sudden they develop this prejudice that, oh my god, now someone's going to start judging me, so I need to eat more. Sometimes they go to an extent where they eat more than they should, and they have to go vomit because of all these social pressures. So I think we need to understand why they are, and that can be due to different reasons. So I think that's what the first thing is, without being condemning them or reprimanding them, because that's only going to make them go distant. And then the thing I often see is, especially patients from other practices, they go switch over to a different practice, thinking they almost somehow they get this concept of feeling guilty, and they stop going to their appointments and things like that. But I think if you make them feel like they have a space to speak their heart out, that's the time you will get better responses from them, and you'll be able to work with them. If you shut them off by saying it's all their fault, very rarely you'll get any success. And I tell the patients that if they succeed in weight loss, all credit to them. Okay, you give them all the credit, give them all the like you're like, oh no, they say, okay, you helped me, no, you did everything. I did nothing in this process. You are the one who's championing through this. So give them all the success. But when they gain weight or they're not, following the diet, take it upon yourselves. Speak in we language rather than you did this or you did that.
That's a very nice perspective to put it. I think compared to other fields, because of the mental toll that it can also take on patients, especially after surgery, that's a very nice way to approach them. Okay, and now we'll transition into more of talking about the professional insights and future of this field. So, starting off, What inspired you to specialize in bariatric surgery?
No, it's again very close to heart kind of a question that you asked, and obviously this is a question that a lot of people ask you, right, including your own family. Like, why are you doing this? What's the thought process? There's only like 10 different other things you could have done. But I will say one thing. Even coming, so I did my medical school in India, and was lucky to do my surgical training here in the United States, to get the state of the art training. But one thing I had no exposure to before I came here was weight loss surgery or bariatrics or metabolic surgery. There was no concept of that. Of course, now that paradigm has changed, even back home. One of the things I often quote is that my experiences in my first year in residency, as they call it, during training, that I was lucky to be able to participate in some of these operations and post-op care of these patients. And I would notice significant improvement in their life when I used to see them in their post-op care 6, 9, 10, 12 months later. And I think that was something I haven't seen, the profound impact even before. Now, I was used to taking care of patients when they were sick. As in, you were, okay, they have cancer, you take their tumor out. Okay. So, but that point is already, that at that point, the ship has already sailed, right? Like, you haven't prevented anything. All you're doing is curing them. But this is part of the preventative process. Like, when you give them the weight loss procedure, it's giving them an opportunity to not get to that point where they need a cancer surgery, or their tumors are lost because of diabetes, or their kidneys are not functioning due to hypertension. So I felt like, as a doctor, the first thing for me is to prevent disease, or at least help prevent disease. And I think that's where this field is unique, that you're actually part of preventing processes that are going to take them to make them sicker down the line. So that was one reason. And like I told you, just the profound impacts of how some of the people or patients that I worked with or knew were not even mobile, for example, or didn't have a regular, like, what I thought was a regular day-to-day activity for them was an ordeal, or would have been it's like they have to arrange transportation, for example, to go get grocery, or they would need someone to pick them up because they themselves are immobile or difficult to move by themselves because of their weight.
Mm-hmm. And how do you stay up to date on the latest advances in bariatric surgery?
Yeah, so as a part of certification, as well as part of what we call continued medical education, or CME requirements, even as a bariatric surgeon, we have a specific target or requirement. So we are all bound to that. And we usually go to these conferences annually, semi-annually, as well as there is a lot of online education that happens. And yeah, that's how we keep up. And obviously peer-to-peer conversations.
Mm-hmm. If you could change one public perception about obesity, what would it be?
Public perception of, yeah, I think the whole concept that, oh, they did it to themselves concept, that they don't think, we never stigmatize hypertension, we never stigmatize diabetes, like, but we somehow have gotten into the habit of considering that, oh, if that person is obese, that's their fault, and that's only their fault, that is. So I think that is the one perception I want to eliminate about obesity, that it is a disease, it is a significant public health problem, and I think stigmatizing that is only making us further distant from the solution.
Mm-hmm. What advice would you give to someone who is interested in this field?
Oh, like to pursue this field as a career, you mean? Okay, yeah, no, I think the first and foremost thing is everybody has a calling, as I would say, and I feel like it's hard to put it in words necessarily how that calling happens. You need to be comfortable, as well as, first of all, you yourself as a provider need to not have that obesity bias. Okay. And that needs to be the first thing you need to eliminate in your own head before there's a saying, you need to practice what you preach. So there is no point in you yourself having a stigma or bias towards patients with obesity. So that's the first and foremost thing every medical professional has to, I think, overcome. And then on top of that, you should like working with these patients. There are going to be difficult days where patients are going to be emotional with you with respect to a lot of things that are going on beyond what you think is like what you think is your problem. It's like you're like, oh no, that's not my. But people are going to go through a lot of physical, mental changes, so you have to be prepared to listen to them.
Mm-hmm.
This is not like just a general surgery practice where you take someone's gallbladder out, you go see them for a post-op visit in 5 to 10 minutes, and everything looks good, and you never have to see them again. This is a constant follow-up process, like I told you, very intense.
Mm-hmm.
Difficult conversations, like we spoke about, have to be had. So someone who's, usually they say surgeons and their patient bedside, you have to have absolutely perfect bedside manners and be willing to speak with these patients, be willing to not speak mostly, even listen to them, and be interested in obesity as a challenge, and take it upon yourself to help the patients the best way you can.
Now we'll be transitioning into talking about some common myths related to bariatric surgery.
Mm-hmm.
Starting off, bariatric surgery is the easy way out.
So, do you want?
I think we touched upon this briefly in our previous conversations that if anything, it is the harder way to do, or hardest way to get out of obesity, but most effective, because it comes with a lot of requirements, nutritional, like I said, psychological, as well as follow-up, and everything is it's more stricter than anything else, because there is actually some program or some person looking over you doing all this, whereas you're doing a diet and exercise, probably a gym trainer and who you can shoo away. But these are like 3 or 4, like dietitian, your doctor, your the nurse, and everybody's kind of checking on you. So I don't think it's the easy way out. There are a lot of sacrifices that patients have to make, including giving up on their most favorite food sometimes, because it doesn't necessarily fit that menu anymore. So no, I think that's the biggest myth. Yeah, absolutely. I think there is nothing easy about bariatric surgery for the patient.
It's just a cosmetic procedure.
See, that's another concept. I do sometimes see patients like, can you just take this part of my belly or fat out? And I'm like, that's not the operation that we're doing. That's something more like a plastic surgeon doing liposuction, which is not going to change anything from your medical perspective. That's where I think the name changing to metabolic and bariatric surgery has made it less of a myth, because it's more like metabolic surgery. So we're altering the metabolism rather than making them just lose weight.
Bariatric surgery has extremely high risks.
Yeah, again, I wouldn't deny that it was the case 40 years ago, 30 years ago, when people were figuring out what to do, how to get rid of this problem. But in this modern day and age, all bariatric operations are, again, when I'm talking about all, we are talking about not revisional or some complicated procedure. I'm talking about primary bariatric operations have a risk of less than 5% complication for any, and probably less than 1% for serious.
You can eat normally after surgery.
I mean, you can. I think you can eat out. Now, this is an interesting thing. What is normal, right? Is the first question. If you think having 3 cheeseburgers for a meal is normal, then that's not exactly normal, right? So the point is, the word normal is a very subjective term. What is normal for you may not be normal for me, or what is normal for me may not be normal for you. So I think if you ask me, can you eat healthy portions and healthily after? Yeah, you can. So I would put it in that way, because normal to me may not be normal to you.
Mm-hmm. Most people regain all the weight they lost.
Again, huge myth. At the same time, I will say I always say this funnily that bariatric surgery is not the next best thing that man invented after bread. Okay, I mean, nobody's gonna, if you make those false claims, that's just uh, that means you're not living on planet Earth and not making realistic claims. So there is about a 20 to 30% chance, and again, these all depends on the type of procedure. There's so many factors. It's multifactorial. Weight gain after bariatric surgery, that's like a whole podcast in itself. But 20% to 30%, depending on the type of procedure, there is a chance of weight regain, but never to a point where they regain all their weight. But I'm talking about just even gaining some weight back. But that again stems from there's time and longitudinal studies showing how post-operative follow-up is a predictor of weight gain after surgery compliance, right? Just like anything else.
Mm-hmm. Oh, this is an interesting one. You can get pregnant after surgery.
You cannot? Is that what you said?
Yeah, you cannot get pregnant after surgery.
In fact, I sometimes have to deal with the opposite end of things. People get pregnant sometimes too rapidly after this, because a lot of these women, especially after with obesity, are suffering from something called PCOS concurrently, and that's a metabolic phenomenon too. And after weight loss surgery, there is almost sometimes complete resolution of PCOS. They say up to 70 to 90% times it's improved or resolved. And so a lot of these women who are infertile or having fertility issues, all of a sudden their fertility is improved. I've seen so many innumerable number of patients who were trying hard to conceive and couldn't conceive, all of a sudden get pregnant within the first year after bariatric surgery, which is not what we want. We want them to wait at least 18 months after bariatric surgery to have a child, only for their reasons. Number one, when you are going through post-surgery up to 18 months, you're losing significant amount of weight, and you don't want to tax your body with having another life to take care of, or basically go on that route, because you're also taking vitamins. You don't want to be losing weight actively while you're getting pregnant, because there's a lot of components from that aspect that the baby's nutrition or the vitamins can get compromised. That being said, is it end all be all? No, nothing. I've seen patients who've gone through pregnancy even within the 18 months and they're going to be fine, but you just are adding a whole different twist to your weight loss journey, and that's just not going to be very helpful, because your body is almost fighting its own self. Like, on one hand you're trying to lose weight, or there's a hormonal surge from the bariatric operation, and on one hand you have pregnancy. So it's oftentimes I have to in fact counsel patients to be careful and maybe even use 2 contraceptive measures in the first 18 months so that they do not get pregnant, and that's more for their benefit as well as their baby's benefit. So on the contrary, it's probably easier to get pregnant.
Bariatric surgery leaves a large scar.
And this was probably true back in, again, going back to before 2000s, but ever since the 2000s have rolled out, I myself I can't even recollect how many open procedures which I would have done for these operations, because most of the procedures, almost 98 to 99% of these procedures are done laparoscopic or minimally invasive. So you would have very tiny scars, 4 to 5 of them, less than a centimeter size at best.
And lastly, why choose bariatric surgery when you have Ozempic?
I think that's a great question. I think just like everything has its place in the society, I think both have a role and both have absolutely a place. In fact, I appreciate the fact that we have such options now, because not everybody sometimes is a surgical candidate. Not everybody may be mentally ready to be a surgical candidate, and sometimes they may want to try this before that, etc. But I don't. So the way we approach this is the concept, just like anything else. Like if you are treating diabetes or hypertension, you want to see change. So if I start you on a medication for diabetes, I want your A1C to come down, right? Yeah. Same thing. If I treat you for weight with Ozempic or GLP-1s, I want to see some effectiveness. So I typically say, if someone has not lost more than 10% of their total body weight in 6 months with any of these GLP-1s, that means they should give a consideration to weight loss surgery.
Mm.
I would be puzzled if someone came and told me, I have diabetes. They put me on a medication, but in 6 months, you know what, my diabetes is still bad. And are you going to be okay with that? No, you would do something else, right? Or you would do a different way. Same thing. If there was something someone started you for weight loss and it did nothing for you in 6 months, would you just keep doing the same? I think that seems just very intuitive to think that you should do something different. So we have protocols we are developing about when patients are on Ozempic or any of these, when should they think that that they've tried enough, or that I think you need to consider surgery. And at the same time, patients who had weight gain after bariatric surgery could be candidates for these GLP-1s too. So it's been very nice to have that option.
And for our final two questions, firstly, what do you believe has changed most from when you first started working to now?
I think coverage, for example, for these operations has changed tremendously. I think people are more in insurances mainly. I've recognized obesity is a health problem. When I first started, and like I told you, there were a very handful of insurances because most of them thought this was quote unquote cosmetic or quote unquote unnecessary. And so I think the coverage, and a lot of that is thanks to the American Metabolic and Bariatric Society, and they have spearheaded a campaign going to the Capitol Hill, going to the senators. There's something called the Obesity Action Committee, and spreading the word of how obesity is a disease and how we need to give a fair chance to people, especially in an insurance-driven country like the US, where it's extremely hard to seek care otherwise.
And lastly, could you tell us about one of your most interesting or challenging patient cases?
I mean, I think, like I said, I would like to end this with a very moving, positive thing. I was telling in my first year, I had a patient who was suffering with obesity, had his weight loss procedure that particular day, and I was happening to be the trainee taking care of him at night, on call, whatever we round on these patients. And he was just having a big difficult moment. He was in tears. He didn't know whether he should have done this, whether he felt like maybe he shouldn't have had this procedure. He was contemplating, one of those contemplating your life choices kind of a thing. He's like, maybe I could have done it myself, maybe I didn't need this, and was going on about it. And at that point, all he needed was someone to listen to all his, sometimes you just need to listen to them, because, they will have these moments where you think, was this all needed? Like, why did I do this? So anyway, long story short, to continue, I was happening to be in my hospital cafeteria maybe a year and a half later, and and again that night I just spent time with him. We just talked over all the details, and we like, you did it for the right things, reassured him. And anyway, that night ended, and then 1.5 years later, I felt a tap on my shoulder at the cafeteria, and I see this person, and he's the security for the hospital. I said, "Oh, this is trouble. This is trouble." And I was like, "Why is the security guard tapping my shoulder? Did I park my car in the wrong spot or something?" But no, it was actually this patient who joined our own hospital as a part of the working force in the security department. And now before his surgery, he was wheelchair bound, or essentially just using a cane or a walker. He was barely ambulatory. He had no social support. He was not working. He was on disability because of his obesity. And here he is. He's lost a significant amount of weight, looking prim and proper as a security guard. And he said, "Do you remember me?" And I said, I couldn't recognize him or even remember. But it's also because of the first year being such a tough year that you want to forget a lot of things. But then, anyways, he said, you spent time that day, and even despite you being so busy, you spent an hour sitting, even though you could have gotten that hour for resting in between a call night or whatever. And I just wanted to say hi and tell you, thank you for that day. And so I think that was a very moving incident of how that little things go a long way. And of course, now he's employed, he's working. He was telling me how he's not on disability anymore, and not a lot of other medical problems of his have become better. So that was one of my I guess more interesting moments.
Very touching. And with that, we've pretty much reached the end of our podcast. So I'd like to wrap up by once again thanking you for your time, input, and contribution. I enjoyed this podcast. It was very insightful and educational. Thank you so much.
Yeah, thank you. And, just as a last message to everyone, I would say, nourish your habits and to flourish your lifestyle. Again, obesity, please consider obesity as a disease and avoid any stigma. If anybody needs help, again, listen to them, speak to them, and obviously encourage them to pursue these endeavors. Again, social support is all sometimes they are looking for.
Thank you.
Thank you.